So today's workshop is Integrated Interventions, Best Practices for Suicidality in Co-occurring and Substance Use Disorders. We know that Suicide Prevention Month is coming to a close, so we hope that this topic will be impactful for us, as many of us think about what our role in suicide prevention across the crisis care continuum is. I want to take a moment to ensure that everyone in the audience is ready and comfortable with the technical aspects of this workshop. As you'll see, closed captioning is enabled for today's workshop. We also have American Sign Language, or ASL, capabilities enabled in this meeting. You can activate it by clicking the interpretation icon on your Zoom navigation bar. If you need tech support during today's webinar, please send a message in the chat. It'll go directly to the hosts, and they'll address it for you then. If you have questions during the presentation, you can enter them into the Q&A area. Those will go directly to us as moderators, and we'll make sure to feed those to our presenters at the end of the presentation. Next slide. We'd like to note that the views expressed in written conference materials or publications and by the speakers and moderators do not necessarily reflect the official policies of the U.S. Department of Health and Human Services, nor does the mention of trade names, commercial practices, or organizations imply endorsements by the U.S. government. Next slide. Today's webinar is hosted by SAMHSA's 988 Crisis Services Response Technical Assistance Center, which provides training and technical assistance to support states, territories, tribal organizations, and community partners across the 988 Suicide and Crisis Lifeline and Crisis Continuum of Care, along with our partners W2 Consulting Corporation and Change Matrix LLC, who have extensive experience with crisis services and technical assistance. The TTAC was formed to support the continued growth of the 988 Lifeline and build a more robust crisis care system. The goal of the Crisis Systems Response TTAC is to support a crisis care system that is integrated, sustainable, and aligned with evidence-based and evidence-informed practices. We'll drop a link to our TTAC in the chat so you can take a look at what else we do. Next slide. I'll quickly introduce our work stream. I'm Megan McGregor. I'm joined today by my coworkers Bree Carr, Stephanie Lagallo, and Stephanie Liu. Next slide. More information. All right. So now I'd like to welcome and introduce our SAMHSA partners whose support and collaboration make these workshops possible. First, I'll introduce Ms. Jill Mays. She's the Division Director of Crisis Systems Transformation for the 988 and Behavioral Health Crisis Coordinating Office. Welcome, Jill.
Good afternoon, everyone. I am very excited to have the honor to introduce SAMHSA's Principal Deputy Secretary, Dr. Arthur Kleinschmidt. Dr. Kleinschmidt currently serves, again, as our Principal Deputy Assistant Secretary here at SAMHSA, where he provides leadership across mental health and substance use treatment, prevention, recovery services, and agency operations. He brings a wealth of experience from his many leadership roles in federal service, including his time as a senior advisor at SAMHSA, a subject matter expert on the White House Domestic Policy Council, and as Deputy Director of the White House Office of National Drug Control Policy. And so, of course, it is very fitting that he's here with us today on our SUD series. But beyond Dr. Kleinschmidt's policy experience and expertise, he's a licensed mental health professional and addiction counselor with over 2 decades of direct clinical experience. But I think probably the most wonderful thing about him is his passion for supporting individuals and families affected by substance abuse and mental health challenges. It's very evident not only in his professional work, but also in his personal life. As someone in long-term recovery himself, Dr. Kleinschmidt has dedicated his life to helping others find hope and healing. So please join me in welcoming Dr. Arthur Kleinschmidt. Art, I'll turn it over to you.
Thank you so much, Jill. I really appreciate that. And I appreciate the TTAC for putting this webinar together. We're grateful to Susan and Mike from the Connecticut National Guard who are here with us today. I kind of want to refocus this, or if you're already focused on this, but everybody who calls the 988 hotline, I want to actually sort of salute them as people who had the courage to actually sort of ask for help. It's not that easy, especially when somebody's suffering or they feel all alone, to actually pick up the phone and sort of ask for help. So that amount of courage, whether you want to bravery or a moment of clarity is something that we all need to be mindful of and salute people for doing that such thing. The 988 hotline has been a tremendous service ever since President Trump signed the order back in 2017, in 2018. So from then on, it has been a valuable service to people who are in need. We need to know as a population, as a citizenry, that mental illness and substance abuse issues are something that are very serious, and it's something that people can overcome with the help of other people. We want everybody to experience the miracle of recovery, to where we could take our challenges, our setbacks, or the things that are giving us emotional pain and turn those into assets once we start getting into recovery and working and helping the next guy. So anybody who is out there suffering today, it's important to know that you're a very useful and a potential resource to other people who are feeling the same way as you. And as you surmount your difficulties, that's very inspiring to other people. And that begins by a simple phone call and asking other people for help. So with that, I really appreciate all the hard work you're doing. I have visited several 988 centers since my time at SAMHSA, and I'm very proud of their effort, and I'm very proud of this program. So thank you so much for all the hard work that you do. Take care.
Thank you both so much for joining us, and thank you for your continued commitment to advancing these integration strategies for us within crisis care.
Thank you.
So here's our agenda for today. First, we'll go over our learning objectives. We'll review the overlap of suicide and substance use disorder. Then we'll hand it over to our guest speaker, who will provide some experience and wisdom from working in that intersection. You'll have time to ask questions, and then we'll move into a mindfulness exercise to kind of ground us before we wrap up for the day. Next slide. All right, through today's workshop, participants will be able to recognize warning signs and risk factors unique to co-occurring presentations, both in substance use disorder and mental health challenges when those are present. They'll apply trauma-informed, patient-centered collaborative safety planning and navigate challenges of care coordination across behavioral health and addiction services. Next slide. As we will be talking about suicide today, we want to remind our participants to take care of themselves during this presentation. We recognize this may be a difficult topic to discuss, so if you need to step away for a moment, please feel free to do so. And remember that 988 is available if you need additional support. Next slide. All right, so let's start by building a foundational knowledge of suicide. It's likely almost everyone here today has been affected by suicide in some capacity, whether it's personal or professional. Over the last 20 years, we have seen suicide rates increase, and in 2023, there were 49,266 suicide deaths by individuals 12 and older. We often use the iceberg analogy when discussing suicide, the concept that the part you see is only a tiny fraction of the issue. So while there were 49,266 suicide deaths, for every individual occurrence, there are also 10 emergency department visits for self-harm, 48 self-reported suicide attempts, and 325 people considering suicide. So with my shaky math, for every one death by suicide, we also have about 373 people now at risk. Next slide. Substance use is a known risk factor for suicidality, but it also has risk factors on its own. So let's take a look at how those intersect. Next slide. All right, so we see our risk factors for substance use disorder. Sometimes it's a family history, adverse childhood experiences, ACEs, chronic stress, grief and loss, economic instability, co-occurring disorders, chronic illness and or chronic pain, and high stress jobs can lead to our risk factors as well. Next slide. So now over here, we'll look at the risk of suicide. And as you'll see, we have very similar ones: family history, ACEs, stress and grief, economic instability, co-occurring disorders. Next slide. So as you can see, one of the reasons substance use disorder is so connected to suicide risk is that they share so many of the same risk factors. On top of these risk factors themselves, we also see acute and chronic substance use as contributing to suicide risk. Next slide. So there are pathways to suicide risk from our proximal or acute and distal or chronic substance use. When we think of acute, we think of that period of intoxication, the behavioral and physical changes we see when using substances that can often increase the risk of suicide. So especially things like blunted emotional response and reduced inhibition. On the other side, in the chronic use, we see that the shared risk factors present a pathway to suicidality, in addition to some of the effects of SUD, including relationship issues, financial issues, decreased decision-making. Both pathways can lead to a heightened risk of suicidality. So it's all substance use disorder that we want to be mindful of, not just that period of acute intoxication. Next slide. The intersection of substance use and suicide is an important area for us to consider when we're thinking about integrating substance use disorder into the crisis care continuum. We saw how significant the overlap of risk factors is, and this amplifies for us the need of integrated care and to standardize assessment for suicide and substance use disorder across care sites to include primary care, emergency departments, and across our medical professions. Next slide. Now I'm excited to introduce to you Sue Tabenkin, who is a licensed clinical social worker and holds certification as a professional in the treatment of substance use. I have had the pleasure of knowing and working with Sue for over 10 years now. Her work at the intersection of suicide and substance use with our service members, veterans, and their families has led to great strides in the state of Connecticut and a safer environment for her soldiers, their families, as well as our veterans. Go to the next slide for a minute. Mike was supposed to join us today. Unfortunately, he is not able to, but Mike also works with Sue. And this is important to know because we really encourage people to not take on these challenges by themselves. Working in teams and identifying those that can support us as we support those with substance use disorder or suicide ideations is really important for the self-care portion of being a caregiver. So with that, I'd like to turn it over to you, Sue.
Thank you, Megan. Hi, everyone, and thank all of you for being here today. I'd like to start with two short stories. One of them, my colleague Mike was going to tell you. I was going to tell you the other one, but now you are in the fortunate position of hearing me explain both of them to you. So I'd like to start this way. A few years ago, I was working with a soldier who was about to retire. He was struggling a lot. Anxiety, depression, very heavy drinking. He was trying to hold his marriage together and figure out what life was going to look like outside of the uniform. And this was very frightening to him. So over the course of several months, we talked about all of these things. The identity that he was going to be changing into, his grief, the transition process, and really tried to give him hope and help him see hope. So one afternoon, I get a call from him. He's outside his lawyer's office and he's ready to file for bankruptcy. He wasn't just overwhelmed, he was broken into pieces. He was crying, told me couldn't see a way forward, and I directly asked him if he was thinking about suicide. He said yes, and he told me he had a gun in his trunk and that he'd been drinking heavily. I paused, and I didn't try to fix anything or throw solutions at him. I just listened calmly, slowly, just being present. And I asked him if he could do something for me. Leave the gun in the trunk, go inside to his appointment, that I would call the lawyer's office and let him know that he was there, and I'd call EMS, and we would, see that he would be checked out and make sure he would be safe. And he agreed to this plan, not because I had the perfect words, but because of the relationship that we built. He walked into the office just as we discussed. I called 911. He cooperated and he got the help that he needed. 6 months later, fast forward, he was in counseling and he didn't end up filing for bankruptcy. He started a small business. He moved from Connecticut to Florida, and he really immersed himself in the next chapter of his life. For the next year or two, I get pictures from him, usually in the wintertime, with him on the beach, smiling and just living life. And that stays with me. And it really does remind me of the work that we do, especially with co-occurring disorders and with people at risk for suicide, because we're not just treating symptoms, we're building relationships to hold somebody together in their darkest hours. So for the next story, I'd like to go through another soldier, but kind of different. I was asked to meet this particular soldier by a supervisor, and she reported that he was struggling at home, but um, he was having difficulty working and just couldn't separate home from work. So I went to the facility. She introduced me. We're on the shop floor, and he was very willing to speak. I was kind of a surprise when I showed up there. So he told me that this marital conflict was escalating. He would fight with his wife several times a day in person and on the phone, and he was drinking heavily. And he admitted to drinking before work to help himself get to work. So I asked him, how long this has been going on, where did it start? And he said his 8-year-old daughter had diabetes. She was hospitalized for some complications. And that's when the stress became overwhelming and the arguments started. So, as we were talking, he disclosed that he had thoughts of suicide. And when I asked him about a plan, he had 3 or 4 different scenarios that he was considering. But he didn't have any thoughts that day. He didn't have any thoughts the day before. And he was agreeing to be safe. But what we did was a safety plan that we worked on together, and we used this, which we'll talk about it a little more later. It's what we call my 6 for my 6. It's sort of a take on the Brown and Stanley safety planning, and we've been using this for a number of years, and I really have to uh, give a plug for Megan McGregor, who was very instrumental in the development and the promotion of this card. So one side has resources, the other side has spaces to put down names of people, phone numbers, things like that. So we went through this plan, we put it together, and he agreed that he would carry this card with him, which fits nicely in his uniform pocket. So we continued. He agreed to have a follow-up meeting. And before he ended, I gave him a little compass, sort of as a metaphor. And I told him something like this. I know you're in a tremendous amount of pain, that you feel broken right now. And if he could keep the compass as a reminder that all he has done so far is stepped away from his path, and that with help we could get him back on his path. So sort of stable, set up, having a plan. Later that evening, he called me and he thanked me for the session and said it helped, and that he had told his wife that he had a meeting with a therapist. So the other part is, he said there was some hard time in this conversation. Him and his wife started arguing. He just ended up feeling hopeless, kind of lost all the positivity, and he was committed in his head to leaving work and driving into a bridge abutment and dying by suicide. So he got up to leave his office and went through this familiar routine, he tells me, of what he goes through, right? Checking his pockets for his wallet, his keys, and his cell phone. And not a real key, something like this, right? A fob that we all have. So he goes out to the parking lot, gets to his car, very distraught, and he tries to open the door, and the car door won't open. So now he is enraged, yanking on the handle, kicking the car, and he puts his hand in his pocket to check for the key fob. But instead of the fob, he found this, which is the compass keychain that I gave him during our session earlier that day. And that was a turning point for him. He decided that he really did have the ability to go forward, to work through these things with his wife, help his daughter, and he became very emotional, and he said he took out the card, and the first number that he put on his safety plan 6 card was his mother. So he got his key fob, drove to his mother's house, and she, went back and forth with him. They had a good dialogue. He called his wife, she came over, and again, the conversation continued in a more healthy way. The story does, continue to have a happy ending. He's alive, very engaged in treatment, and he's very grateful that he didn't die that night. So that silly compass, the unassuming, tangible reminder, became a literal turning point for this man. And this is an example of how brief, person-centered interventions, practical safety planning, and small symbols of connection can interrupt a crisis and create a safe space for recovery. So, suicide prevention and substance use often operates in silos. And our job in what we do every day here at the Guard is to create connection. We do this through a lot of partnerships, the VA, crisis lines, local hospitals, and we also do a lot of reporting to get the Guard family, leaders, peers, to connect with each other. So you can see on the slide, there's the Foxtrot model, and this is where the Foxtrot model comes in. It's not just a framework for documentation. It's really a process to have a very human-centered map for connection, integration, and recovery. And today, I'll go forward and walk you through the model. I'm going to use some more real case examples to show you exactly how to find, flag, follow, fix, and free. And it's not just a process, it's really a lifeline. Next slide, please. We're gonna look at when substance use and mental health conditions overlap. Suicide risk doesn't look the same as it does in a single diagnosis. As an example, intoxication may hide a depression, withdrawal can suddenly intensify things like hopelessness, and it can change how things are shaped. So we'll look at those spots and those unique warning signs. Safety planning works best when it's collaborative. Instead of just having a checklist, we have a complete conversation. We use trauma-informed approaches to be sensitive, to avoid re-traumatization, and to build active plans that reflect the client's own voice and in a very cultural context. So prevention doesn't happen in isolation. It's aligned with mental health care, substance use treatment, and crisis services. And we're going to explore ways to reduce those gaps so clients don't fall through. And finally, we're going to explain about utilizing the Foxtrot model, and we're going to apply this model to our case examples as we go on. Next slide, please. The Foxtrot model gives us a clear framework for addressing suicidality and co-occurring disorders in ways that are coordinated, person-centered, and practical. Each phase, from identifying risk to supporting long-term recovery, helps us shift from reacting to a crisis to being proactive and implementing sustained care. So we're going to walk through the 5 Foxtrot stages in detail, but think of this model as a roadmap to integrated intervention across the entire continuum. Next slide, please. All right, these are the steps as I've been sort of briefly talking about. Now I'm going to try to dive in a little more. Number 1, the find stage, that's where we identify the at-risk person through whatever screening there might be, through people who suggest that someone is at risk and that we reach out. There are a number of different programs. In the Guard, there are yearly periodic health assessments. Command oftentimes will refer someone when there are major life stressors, legal events. Oftentimes people come on our radar. We also have internally developed what we call the behavioral health questionnaire, and we use that at these different assessment events, and that helps identify areas that need to be addressed. So we ask a few different questions in many different areas, and it really runs the gamut from whether they have health insurance to unit cohesion to self-care, and we collect all that data and we try to identify any trends. And if there's something that is highlighted, we look to communicate that to command to have more of a intervention, a briefing to help promote prevention activities. The flag stage, we may have to assign a behavioral health profile to help communicate duty limitations and care plans in plain, common layman language. Under the follow stage, we do case management. And what we think of as case management is regular contact, tracking progress, ensuring compliance with care plans. So overall, we're supporting the service member and their family with whatever needs that they have. In the fixed stage, we connect soldiers to treatment, mental health providers, substance use care, peer support, chaplains, or just general community services. We also provide solution-focused interventions. Myself, Mike, other members of our team give that directly to the service member, and that delivery ensures that immediate issues that may be less complex can be addressed quickly and efficiently. And then finally, we get to the free stage, which that's when we return them to duty if possible. And if not, we help them with a very dignified transition through a medical evaluation system. So this little framework that I've plowed through for you is our way to help maintain readiness, promote recovery, and support retention. Next slide, please. All right, so I'd like to go over a case study of a service member. He is, excuse me, a 25-year-old male veteran. He works in a shipping department and lives with several roommates. He's got a diagnosed history of PTSD, unstable mood, maybe bipolar disorder, and very significant alcohol use. So over a month period, he began to seriously decompensate. Intense anger, panic attacks, flashbacks, some escalation in his drinking, and especially binge drinking. And all this occurred after a fellow veteran passed away by suicide. His alcohol use went from a few shots to 15 shots on the weekend. And he had some intense thoughts about harming other people, although he never acted on them. So he voluntarily asked his girlfriend to move out. He had a lot of fears that he would hurt her, and he had a very serious outburst at work. And a friend of his who also worked with him, very trusted friend, and his supervisor that he had a good relationship with, referred him to us, and ultimately he did ask for help. As that went on, he shared that he had previously attempted suicide and that he had access to firearms, but he had given all the firearms that he possessed to a friend. It seemed that he needed a much higher level of care than just an outpatient back and forth couple times a week. So proposed this to him, and he agreed to inpatient care. He was concerned about his job and concerned about legal trouble because of his behavior, but he was open to this particular hospitalization and did very well. And that was a foundation for a lot more recovery. So he had been resistant in the past to treatment, but he was able to gain insight, to be open, and have a desire to get control back to his life. So this case, for me, really highlights the way that peers come into play in getting help, getting treatment, getting life back on manageable terms, um, by using the peers, having friends, trusted people who can really help intervene early and, maintain a trusting relationship. Next slide. So in the fine stage, it came through his escalation of his behaviors, his outbursts, his panic attacks. But what's really important here is that it wasn't just the professionals that noticed, right? His girlfriend, close friend, his supervisor urged him to get the help. When the severity of his condition became untenable, he was experiencing those thoughts of harm, damaging property. He talked about particular instance of when he put a gun to his mouth and what that felt like and what went through his head. And that was when we really recognized how things had escalated. So the more we engaged with him, the more, despite his initial hesitation of being afraid, thinking that this was weak, that he could do things on his own, we really did develop a trust that went back and forth. And that really was a turning point for him. He was in a more reflective, insightful state of mind, and he was more willing to take some responsibility for his own safety. So there was some clinical stabilization that went on through hospitalization, through use of medications, and through some real trauma-informed care, and some very pointed treatment of his alcohol abuse. Um, and the other thing that has kind of been sort of not highlighted in my story was the grief and loss that we connected to his condition, to his behaviors over the loss of his friend. And then we focused on ways for him to sustain his recovery and again, to maintain employment and to not get into any trouble, to manage his thoughts of angry outbursts. So he continued on with the therapy, still had a lot of peer support, and was more structured in the relapse prevention. So, as you can see, this wasn't a one-phase intervention. It was a full continuum. We built the trust in the find and the follow stage, and that trust, that development of that relationship really made the free stage possible. So this model gave us a way to track his care across all the critical points, and ultimately we supported both his survival and his recovery. How about the next slide? So this is another case of a service member, white male, who lived with his wife and 13-year-old stepdaughter. He had a lot of trauma symptoms related to his combat exposure, had a few suicide attempts, and psychiatric hospitalizations. His mood was very depressed, was hyper vigilant. He had an increased startle response, and he was endorsing suicidal ideation. And he did have thoughts of jumping off a parking structure or some high bridge or something, but he didn't act on any of that. He was also abusing some prescription medication, some opiates, as well as alcohol, that were prescribed for some shoulder injury that he had, and that was, needing surgery, but he was kind of avoidant of the surgery. So we again made connections between his mental health treatment and his substance abuse treatment, got them to work in conjunction with each other, made sure there was a connection, followed the care plans. And the other part with this soldier was his compliance. He would oftentimes begin some treatment, begin a plan of recovery, and somewhere along the line it would drop off. And with him, that being working together, that trust relationship made a difference. And it made a difference in the way he communicated with us, the way he communicated with treatment providers, the way he communicated with his family. And slowly but surely, he got into a stage of stabilization and was able to use community supports really well. So let's go to the next slide. In his case, the Foxtrot model worked um, this way. First, he voluntarily came to our program. He was clear to identify his high risk situations, and how his combat trauma kind of played into those. We documented and communicated his thoughts, his history, made a good care record. We did a lot of following, monitoring, encouraging through hospitalizations, through substance abuse treatment, through uh, stabilization and community involvement. And again, all these things were integrated, right? We made sure that he wasn't just in one type of treatment for one disorder, but having them all kind of fit together, right? Work together in conjunction. And that also helped reduce a lot of barriers, and it also made communication a little easier. So it was really about coordinating care and stabilizing him. And the goal was supporting him in his recovery and his functioning, and there was a major reduction in his risk for suicide. Next slide, please. So at this point, I'd like to pause, and maybe we could reflect and think about what we've just worked through. So we've used this Foxtrot model, the find, flag, follow, fix, free, as a guide to walk through the behavioral health journey of these two different service members. So now I'd like to ask you, which phase do you think is most overlooked in your setting? Is it the initial find phase? Is it the follow phase, where we often lose clients because of lack of coordination or continuity? Or perhaps it's the free phase, the part where we're supposed to set people up for long-term recovery, reintegration, and life beyond the crisis. And it's not really rhetorical, this question, if you think about it. In your organization, which phase needs more attention, more structure, more resources. When we overlook even one of these stages, the whole system becomes reactive instead of proactive. So with us in our setting, oftentimes the follow stage highlights a number of challenges. It requires, and the reason I think this is because it requires consistent and ongoing engagement. So after the initial crisis passes, oftentimes focus gets lost by the client, by the provider. Once people leave emergency rooms, inpatient units, crisis services, the responsibility for follow-up is oftentimes very fragmented, and people can fall through the cracks, fall off the radar, and end up being re-traumatized or in a repeated crisis loop in a way. So without that intentional follow-up, the coordination, that is the fear that they'll fall off the radar and that they'll get disconnected from services. Next slide, please. So just to summarize a little bit, our review of cases shows that peer, family engagement, ER access, and proactive help-seeking behaviors are valuable system strengths that support suicide prevention in co-occurring populations. However, we often see stigma. Gaps in care, also gaps in care between mental health and substance use services, and the limited follow-through that remains a significant challenge and undermines continuity and safety. So to address these barriers, systems have to strengthen handoffs across providers, build trauma-informed approaches, and expand the role of peers as a trusted bridge between clinical services and recovery communities. Next slide, please. So these are some of the evidence-based tools that we oftentimes use, as we've kind of talked about, or again, shameless plug for my 6 card. It's not just a document. It's not a form to check boxes. It's a very living, breathing tool that gives people very concrete ways to go through steps to stay safe when there is the sense that this crisis level is about to occur. CAMS that focuses on the suicidal drivers themselves. It invites the client to take ownership and identifying and addressing what makes life unbearable, right? What the pain is about. A motivational interviewing is very powerful in the treatment of substance use. It oftentimes will reduce resistance, and it'll help the client move from ambivalence to action. We use trauma-informed CBT, that combines practical coping skills with awareness and how both substance use and suicidal thinking are combined. EMDR, again, is often an effective tool for people to process painful memories and reduce the intensity of intrusive thoughts. Medically assisted treatment, again, very useful in opioid abuse and alcohol abuse disorders. It helps reduce cravings, withdrawal symptoms, and we see that it lowers relapse risk and reduces the vulnerability that people feel around suicide. And again, back to communities and families, we can't overlook this. That helps with the stigma, as well as increasing communication and assistance in engaging in treatment. And then the peer mentorship, having someone with lived experiences to walk alongside you, oftentimes bridges that gap, helps them get past those roadblocks to continue to engage in treatment and really seize on the hope. So taken together, all these interventions remind you, I hope, that there is no one single solution, that it's about integration, about using multiple tools and building safety, trust, and eventual long-term recovery. Next slide, please. Again, a bigger example of one side of the 6 for my 6 card, safety planning. Again, a vital, dynamic, useful tool. Next slide, please. So as I close out, I'd like to just review kind of a few things that I think are good takeaways. Suicide risk in individuals with substance use disorders demands a real special kind of vigilance. They're not isolated issues. They amplify each other in dangerous and very complex ways. Second, integrating screening and safety planning aren't just the best practices that we talk about. They are life-saving tools, truly. The more trauma-informed, coordinated, and client-centered our approaches are, the more effective these tools become. Again, care coordination is not an administrative task in our world, it's a clinical one. So hopefully these real-world vignettes that I've shared today remind you that the work is not theoretical. The models can be replicated and the lives can be changed. And if you're not planning ahead from one stage to the other, from follow and free, you're just treating the crisis. You're not really looking at the whole person. I'd like to take a minute now to thank you for listening. Thank you for the work that you do and for the care that you bring to it. And we all need to keep pushing forward, not only to intervene, but to support long-term recovery and keep patients moving forward with a dignified approach.